Okay, so for Unit 4, we're talking about bioavailability and bioequivalence and what that actually means. Shorter section. We'll talk a little bit about adverse reactions, kind of what that means. We'll talk about the difference in types of adverse reactions, things that may be considered a side effect versus something that can be a little bit more serious. So talk about that, and then bioavailability and bioequivalence. We'll just describe what those are and some ways we can actually change that, modify it, and how it may affect our patient. Anyway, so an adverse reaction. What's an adverse reaction? Non-intentional, some sort of side effect, kind of an untoward event, something you did not actually mean to happen when you give that drug, right? So it's usually an appreciably harmful or unpleasant sort of reaction. In some cases, it's going to require an intervention or the use of, say, other medicinal products in order to help combat that, right? Not always, but depending on the severity, sometimes you can just say maybe stop the medication or maybe change the dose. But in some cases, you have to actually intervene and give them something else. So, for instance, if I had someone who took too much of their say Percocet or they had too much morphine or something, and they became very CNS depressed and they were respiratory depressed, I'd have to give them that antidote we talked about, that Narcan, in order to help intervene with that. That would be considered a sort of adverse reaction that you can have to that type of medication. Okay, this is one example. And again, this helps us to predict kind of future hazards with some of these medications. If you have a really bad reaction to one medication, maybe I don't give you that medication anymore. Maybe we can do things like modify the dose that we're administering, maybe changing the actual regimen, or in some cases, you can just stop the drug altogether. This can always be kind of the end game there, and say, okay, you're just not going to respond well to that drug. We're going to give you something different completely. So there's kind of 6 main categories we're going to talk about here as far as adverse reactions go. There's going to be some that are going to be dose related. And again, this is a weird mnemonic. I don't really use this too frequently, but if it helps you to remember it, that can be useful. It's kind of this A, B, C, D, E, and F mnemonic here. So again, if that's useful to you, more power to you. But there's going to be things that are going to be dose related. We're going to run into some reactions that are going to be non-dose related. Some of these are going to be dose and time related. Some of these are just time related. There's withdrawal, which again, if you're taking away the medication, and then failure of therapy. Okay, so we'll go into specifics on some examples of each one of these as we go forward. So looking at dose-related or kind of augmented responses you're going to see with some of these medications, these are pretty common for the most part. And again, these are going to be related back to the pharmacologic action of the drug. So for instance, if I'm taking an opioid for pain relief, I know it's going to act on opioid receptors, especially like in the spinal column and elsewhere. If I increase that dose too much, that's where I can run into issues of like CNS depression, respiratory depression. It's all related back to the dose and still looking at the pharmacologic action of the drug. It's just we got too much of it around essentially. But it's pretty predictable, and in general, it tends to have low mortality for the most part. This tends to also include a lot of side effects and things like that. So I mentioned if you have side effects that can kind of consider to be kind of a more minor sort of effect, kind of a minor version of an adverse reaction. I'll show you some comparisons here in a minute. But side effects, can be things like opioid-induced constipation. That would be considered like a side effect related back to the pharmacologic action of those opioids, right? Other examples would be things like sedation with antihistamines, like Benadryl, right? So normally take a dose of Benadryl and you become very sleepy. If I'm taking this for allergies, then that could be a side effect, right? However, if I'm taking it for insomnia, that's actually the desired effect, okay? So in some cases, an adverse reaction may not always be an adverse reaction depending on the intent of the use of the drug. Another case would be like calcium channel blockers, which we use as antihypertensives. If I have the dose too high, I can run into hypotension, right? Conversely, remember we talked about beta blockers and how that slows down the heart. If I develop bradycardia, that would be a similar kind of adverse reaction you can see with this. And again, it's all related back to dose. You have non-dose related. These tend to be kind of, we call these bizarre because they're kind of non-predictable. They tend to be not really related to pharmacologic action. These can have higher mortality, as you'll see. So for instance, you can kind of consider things like, allergic reactions, maybe to penicillins. Again, can you predict accurately who is going to have a reaction? Not really, right? You have no idea who's going to be, unless you did testing prior to, which we don't do normally. Or in some cases, anyone ever heard of malignant hyperthermia? Something you may see kind of talked about like in either like the ER setting or more commonly in the surgery setting. But this is something that can happen as a very severe reaction to either general anesthetics, usually either gases you're inhaling during anesthesia in order to keep you knocked out, or a paralytic called succinylcholine. And again, we cannot determine who's going to have a bad reaction because it's a genetic thing and you don't test for it normally. So again, that's something that is not related to the action of the drug itself. It's just something that the patient may be predisposed to and you just don't know about it. You have dose and time related. These are going to be more chronic issues that pop up, and these are relatively uncommon, but actually have to do with kind of cumulative dose and time. So say, for instance, I'm taking steroids for a good long period of time. We mentioned when I'm taking those steroids, like things like hydrocortisone or dexamethasone or prednisone, we mentioned that that normally is going to activate that negative feedback loop for cortisol production in the adrenal gland. We mentioned that normally that will say the adrenal gland says, hey, we have enough steroids around, let's go and shut off production. And then if I were to withdraw that immediately, then I can have adrenal suppression that happens there, adrenal withdrawal that can be pretty problematic. So that's an example of being related to the dose of the drug, how much I'm giving, and then also the time frame that I'm giving it over, right? So it's kind of a more chronic issue. Some of these are just going to be time related, so it's not necessarily related to the dose, but these tend to be uncommon as well, and usually becomes apparent after the patient's been taking the drug for quite some time. So a good example of this would be something like teratogenesis. Anyone familiar with that term, teratogenesis? What is that? Kind of birth defects caused to a fetus due to maternal drug exposure to the mom, right? So for instance, if you have a drug that we sometimes use for seizures, sometimes we'll use it for bipolar disorders called valproic acid, or like Depakote is a brand name, or Depakine, you may have heard of that. You can have neural tube defects on the fetus, right? So again, it's not related to the dose necessarily, but because the fetus is exposed to it, and again, does every pregnant woman know they're pregnant? Not necessarily, especially very early on. And so you could have this exposure occurring that you actually don't even realize until the baby's born, or you're doing ultrasounds and realize, hey, there's some odd shapes going on here. That could be one thing. Another example would be a serious side effect called tardive dyskinesia that you can see with antipsychotics. Patients with like schizophrenia may be on these drugs for a very long period of time, and they develop some of these tardive dyskinesias. Kind of looks a little bit like Parkinson's disease, and it's just related to how long they've been on the drug for, essentially. Some of them for years before they will actually develop some of these issues here. We'll talk again more about these in detail in actual pharm courses. You can have withdrawal reactions. We talked about a few of these. Remember I mentioned beta blockers, how you can end up having chronic blockade of those beta receptors, and what do those receptors want to do in response to that? Do they upregulate, downregulate? Yeah, they're upregulated when they're being blocked constantly. And remember when we said we took away the beta blocker all of a sudden? Now we have all these receptors that can interact with epinephrine and norepi, and what happens? You have hypertension, you can have tachycardia, you can have MI be induced in those cases. That would be considered kind of a withdrawal phenomenon. And again, it's only going to be related to certain drugs. And a lot of it goes back to the half-life of the drug. So again, we mentioned with drugs with longer half-lives, they take longer to clear out of the body, right? So if I can use a drug that maybe has a really long half-life, they'll have kind of a nice taper effect. So for instance, if you're looking at, say, like a drug concentration here, and again, I apologize for my drawing skills here, not being great. Imagine I were to have one drug where, say, I'm kind of at steady state and it has a very short half-life. If I discontinue immediately, you're going to find the drug levels will drop pretty precipitously down to 0, right? And that could lead to a withdrawal effect. However, if I were to give another drug, say, for instance, something that has a longer half-life, if I were to give it continuously and then stop it, you'd kind of notice a more kind of gradual taper to it, which can actually help to eliminate a lot of the withdrawal phenomenon. So I don't know if anyone's familiar with anyone who takes like an SSRI for depression. One of the things you'll notice is that they come off of their antidepressant very quickly. They can have a lot of rebound effects. And again, people who have depression may not be the most compliant patients, especially if they don't have their depression really under control. And so if we're worried about them coming off their meds all of a sudden because they feel like they're not working or for whatever reason, we will preferentially give them something with a really long half-life to make sure they don't have these withdrawal symptoms that occur there. Okay, so again, one reason why we might choose one drug over another based on the type of patient we're dealing with. Okay. Another good example is opioid withdrawal. Again, those patients tend to be very, very cranky, especially if I give them something to block all those opioid receptors. They get very upset with you for putting them into withdrawal. They'll start, having a lot of vomiting and diarrhea because you've taken away all that effects on the GI tract. They get very, very anxious, very, very upset when they don't have that drug around. So again, withdrawal can be a pretty serious complication of immediate discontinuation of a drug. Okay, some other ones you can have kind of unexpected failures of therapy. These can be pretty common. A lot of times these are dose related, and in some cases you may find that it is due to drug interactions essentially. So for instance, if I'm giving, say, 2 drugs concurrently, or say for instance, we talked about our fluoroquinolone example, I'm taking that orally, and then I'm drinking it with a big glass of milk, that calcium binds up all those fluoroquinolones, and now all of a sudden I still have that bacterial infection, I haven't gotten rid of it, but it never really got high enough concentrations in the system to really do anything in the first place. That could be one example of a failure of therapy. Other good examples would be things like oral contraceptives, which are estrogen and progesterone based. If you had an enzyme inducer on board, if I was upregulating enzymes to break down those drugs faster, then they may not have high enough concentrations to adequately hit that negative feedback loop, and then I can still have LH and FSH actually cause ovulation to occur, right? And then you can have a pregnancy happen. So again, those are typically going to be most often caused by drug interactions, or be the most common reasons why you might see this. Okay, so I mentioned, side effects tend to be kind of, usually don't require a ton of intervention, if anything at all. Typically, they're kind of undesirable, but they're not necessarily as dangerous as you might see for some of the more kind of serious adverse reactions. I'll show you some comparisons here in a second. But side effects can be good things sometimes. So is anyone familiar with Latisse, bimatoprost? Well, if you have short eyelashes, maybe this is something you are interested in. But this is actually a glaucoma medication that we were using to help kind of decrease intraocular pressure for patients with glaucoma. And what they also noticed, those patients were getting like really long, nice eyelashes. And so now they have they were able to get a new patent on the drug, have a new brand name, and then market it specifically for increasing eyelash length. So that's where you get Latisse from. One of the unfavorable side effects, it can actually turn the iris brown. So again, if you have nice, pretty blue eyes, do you want to necessarily risk turning your irises brown? Yeah, who knows, right? And again, a lot of times it tends to not be reversible. However, if you already have brown irises, guess what? Probably doesn't matter at that point. You just go and use it all you want, right? So again, some of these adverse effects can be positive. Sometimes they can be negative, depending on kind of what's going on here. I'll show you when we actually talk about ocular meds a little bit later. But if you Google pictures of Latisse, you can actually see, one eye being treated versus another. They'll have really long eyelashes, sometimes more of a brown discoloration to the iris more so than the other eye will. It's kind of interesting, but we'll look at that when we get into glaucoma in the next semester. But a good example of an adverse reaction versus a side effect. So, has anyone heard of the drug Bactrim before? It's a pretty common drug used for UTIs, skin infections, etc. It's a combination of two antibiotics, one called sulfamethoxazole, and one called trimethoprim. And working together, they work to kill off bacteria. So one of the things you can find, a side effect may be considered something like rash and urticaria, right? So again, this is something where we may have, especially like sun-exposed areas, we call that photosensitivity. That may be a little bit, problematic for the patient. They may not really care that much. In some cases, they may lead to discontinuation, but sometimes patients will just take it through and maybe just put on some extra sunblock, stay out of the sun, and they're okay. On the other hand, they could have a much more severe adverse reaction, something like Stevens-Johnson syndrome. Anyone ever heard of that? The very severe skin reaction that happens. So basically, you have blistering, the skin starts to slough off, and that's why you need to educate. Anytime you're giving a drug that can potentially cause Stevens-Johnson's, anytime you see any kind of new rash or anything like that, they need to have it checked out, right? So again, side effect may be problematic, maybe not for the patient, but not usually as severe as something like a true adverse reaction would be. Okay. Another example would be Viagra or sildenafil. Normally, we said we use it for what? Yeah, erectile dysfunction, absolutely. So again, a side effect can actually be upset stomach. We mentioned, and we don't have to memorize this for the test, but specifically, we mentioned it's a phosphodiesterase inhibitor. It actually helps to, we mentioned how it can affect the eye, potentially cause blindness. That would be definitely an adverse reaction. If all of a sudden I was like, getting ready for a Friday night, take my Viagra, and all of a sudden I go blind, not great, right? That's not how I probably envisioned my weekend going, right? However, a side effect, you can actually get some upset stomach. One of the actions of the drug can actually loosen up the smooth muscles surrounding the esophagus. So basically, you can have the pylorus into the stomach actually become a little bit loose, and that can cause reflux of acid into the esophagus, right? So it could be, upset stomach, kind of side effect. Maybe I can take some Tums with it or something to help neutralize that acid, but not a big deal, right? Blindness, big deal, right? That's a problem. Another example would be something like an ACE inhibitor. These are going to be drugs we use for hypertension pretty frequently, and so a good example is lisinopril. Now, a side effect could be cough. Cough is a very common side effect you're going to find with the ACE inhibitors, and it's due to a buildup of a product called bradykinin. So they may have just kind of chronic dry cough. A lot of times it kind of is annoying enough to the patient where they're going to switch over to a different class of drug. However, more seriously, you can develop what we call angioedema, right? It's a kind of a version of an allergic reaction where they get very swollen tongue, the airway becomes very swollen, and this is potentially life-threatening, right? Because again, when you get that swollen, what can close off? The airway, right? So at that point, you got to worry about intubating them, but their tongue's so big, you can't even, get an endotracheal tube down. Sometimes you have to do cricothyrotomy in order to get an airway. It's not good, right? So it's one of those things where you have to be very, very careful and educate if this is a potential side effect, right? Or a potential adverse reaction. You need to let them know that's a possibility. Okay. So how do we prevent adverse drug reactions? Well, there's a couple of things you want to look at, and we call these the 5 rights. A lot of these are going to seem like super obvious things, right? Okay, make sure you give the right drug to the patient. Well, duh. But does that get screwed up? Absolutely, all the time. Well, not all the time, but it happens often enough that we put things into place to try to prevent this from happening, right? And again, whenever you see a sign that says, like, don't do something really obvious and stupid, why did it have that sign in the first place? Someone did that thing to necessitate a sign, right? So again, people are prone to make mistakes. People do things, and this is the reason why we have all these safety features in place, because humans cause errors. Humans are prone to that. And so, you guys ever heard of the Swiss cheese model? That's referencing. So we talk about adverse drug reactions. We talk about any kind of like med safety stuff or any kind of medical error. We talk about the Swiss cheese model, where basically every step of the chain, from the time that the provider's ordering, say in this case, a medication, to the time that the pharmacist is verifying the order, the time that they're dispensing it, the time that the nurse receives the drug, and then the time they give it to the patient, there's multiple steps there where there could be an error. There's also multiple steps where the error could be caught. So for instance, if a doc orders something incorrect, and I'm catching on verification, I can call them up like, hey, I think you actually meant to do this instead of this, and say, okay, great. However, if they order it wrong and then I miss it, now some holes of the Swiss cheese are starting to line up. And then if the nurse gets the drug and she doesn't even look at it, and go ahead and decides to give it to the patient, now all of a sudden all those holes have lined up, and now that error has occurred, and the patient gets the wrong drug, or they get the wrong dose, or whatever it happens to be. So you'll hear about that Swiss cheese model again whenever you're talking about medication safety stuff, or even just any kind of medical error stuff. But again, you want to make sure you get all of these right. Do this every time to make sure you don't cause any problems for your patient, right? So we're talking about the right drug, right patient, right dose, right route, and right time. So it can definitely be harder than you think, especially when you have drugs with like confusing brand names. You may see things like, here's an XR formulation, here's an SR formulation, here's an ES formulation. They all have different meanings. They can vary between different drugs. And so XR may mean extended release versus a sustained release. And for instance, we deal with this pretty commonly. So for instance, there's an antidepressant drug called bupropion or Wellbutrin. Wellbutrin has an XL formulation that's 1 time a day, and there's a twice daily formulation called Wellbutrin SR. And so, and again, when you go into the hospital, who does the actual, kind of reconciling the medications typically? Anyone know? Typically, the nurse is the first person that kind of looks through their med list and kind of writes stuff down. If they transcribe something wrong, and then the doc goes through and they're doing the admit orders and they're ordering the medication again, then that can be carried forward. That error can be carried forward, and then we verify it, and then the patient gets the wrong dose. Either they get a double dose or they get a half dose compared to what they should have gotten. That's a possible error that can happen there. You'll often find this a big issue with over-the-counter products. So again, when you say NyQuil, what does NyQuil mean, right? There's lots of different NyQuil products that are out there. We say Tylenol, right? Tylenol wants to put their brand name on everything, all the different products. So that way, when a patient says, oh, I take Tylenol, what kind do you take? What dose do you take? You need to make sure you're being very specific with that sort of thing, right? Also, being in Florida, being in Orlando specifically, we have a lot of, we're a travel hub. We have Disneyland here, Universal and all of that. We have a lot of foreign patients coming in, and oftentimes they get sick and they come to see us, right? Good examples of this, especially like Make-A-Wish trips. Like we have a ton of kids that end up coming into Florida for Make-A-Wish trips, and then when they're stressed out and they're going into a new environment, they're, there's a lot of microbes and stuff at Disney, all these kids running around sneezing on stuff. Those kids get sick, and then they come over to us. And sometimes they're from other countries, sometimes from South America and UK, and they will have different names for medications. And so it's our job to make sure we're, figuring out what those are to make sure we can give them the right US medications or the right US versions. So for instance, if you ever hear albuterol, anyone know what you use that for? For asthma, it's usually like an inhaler, obviously used for asthma. If you ever hear salbutamol, that's what they call it in the UK. The salbutamol is just we would call albuterol over here, same drug, but you need to know that to make sure you're getting the right stuff over here. Another good example would be paracetamol. That is the UK version of acetaminophen. If you're here, paracetamol, if you're watching like your BBC America or something, that's what they're referring to there if you're watching that. I find a lot of meds, especially from like South American countries, so like Brazil, so everything's in Portuguese on the prescription bottles, or from like other places that are speaking Spanish. We have to go through, and you know what I use to translate stuff over? Same thing you guys probably use, Google Translate, right? So I just pop it in, see what it says, and okay, I'm supposed to take this, taking this twice a day. Sounds kind of crude, but Google gets the job done most of the time. So work on your Google foo, as I say. It'll get you out of a lot of hairy pickles there. All right, so then going on to the right patient, name alerts are a big deal. This has been driving me crazy. The past couple weeks I've been at Nemours. We have a NICU there, and of course sometimes twins will come in and they'll put them in the same room. And so they say like 2 designations. They'll have, say 3115 room A and 3115 room B. There's the same room, but you're just either patients on either side there, right? So when twins are born, do they always have a name? Not necessarily. So you'll have twin A and then you'll have twin B. So naturally, I would think you'd want to put twin A into the A room and you want to put twin B into the B room. Did they do that? No. So now twin B is in the A room and twin A is in the B room. And so when you're delivering medications, you got to make sure you're delivering the right ones to the right patient. You know, they may be completely different sizes, and maybe completely different, require different medications. It's rife for medication error. So how do we get around that, right? So we can do things like barcode scanning. So if at our hospital, every single patient comes in with a barcode on them, and the nurse needs to scan that to make sure they have the right patient. Okay, so everyone has a unique barcode to them. However, if a nurse goes and just gives the medication prior to barcode scanning, they give the medication, they go back and they scan, and it comes up wrong. Guess what? Barcode scanning didn't do a whole lot of good in the first place. So again, that's why I always tell our nurses, like, make sure you scan first. Always scan first. It takes a little extra time, but will save your butt in some cases. Patients move around the hospital all the time. You know, they say, you know, give the med to room in patient room 5113. That could have changed 3 times today, depending on where you're at and kind of with you know, kind of the workflows in that unit. So again, you need to be very specific. Say, hey, give this to John Doe so-and-so. Here's their date of birth. Here's their MRN, because you want to get all those patient identifiers in line, so make sure you give them the right med to the right patient, right? Oh, the other thing is, like, you know, we have a high Hispanic population over at more specifically. So like you're in the ER, and there can be several patients, several Smiths, there'd be several Rodriguez's, several Garcias, and you got to make sure, okay, well, which patient am I in the ERs are very fast turnover. So again, those rooms turn over all the time. So making sure you're giving the right patient the right drug, right? So again, that's why barcode scanning is very useful there. Other things, so the right dose. Okay, make sure we're making the dose correct based on the age of the patient, the gender. Gender doesn't factor in too often, but you know, the renal, hepatic function, etc. These are important things you want to make sure you're looking at proactively whenever you're ordering a medication for their patients. And that's why home medication reconciliation is super important for those inpatient encounters, right? So a really good example of this. Anyone familiar with the drug methadone? Probably mention it here briefly. It's an opioid usually used. It's a very long-acting, very strong opioid used to help patients get off of their opioid addiction, right? So used to help them kind of wean them off of that. And so usually they go to the methadone clinic and they'll get their drug. This patient, however, was going into the hospital. No, our hospital is an adult hospital. Patient was coming in, and basically their system was in the ER. They would have a pharmacy tech go in and they would do the medication reconciliation. They would take it back to a pharmacist. They would verify it, and then when the doc actually orders it for the admit, they would just reorder everything or whatever they want to continue. They just reorder it. So one of the things you'll learn whenever you're interviewing patients is that when you're asking about how much they smoke, you always double that. Ask them how much they drink, you always double that. And you ask them how much methadone they take, you half that. Because again, patients lie, right? So anyway, so we had this guy come in and he was saying he was on methadone, and the pharmacy tech went ahead and verified, okay, you take this much. It was a very high dose, but it wasn't something completely unheard of. Like you could see, because again, due to tolerance, patients can take really high doses of opioids. And so the tech didn't think anything about it, sent it to the pharmacist. Pharmacist said, oh, it looks high, but okay, that sounds good. And then the doc went ahead and ordered it. So the patient was lying pretty significantly. It was getting like, you know, 4 times the dose what he normally would got. No one actually called and verified with the methadone clinic what they should be getting. So next morning, the nurse walks in, patient's completely zonked out, had to give him Narcan to reverse it to wake him back up. Okay, so again, it's one of those things where you want to trust but verify, and medication reconciliation is a big place where this can be kind of fraught with error, right? So again, especially drugs like that, you want to call it. And we'll talk about opioids later on, but there's some big changes. I'm familiar with the new House bill that is going into effect July 1. Huge effects on how you guys are going to be prescribing opioids in the future, especially when you're monitoring them, how they're actually getting their meds, where they're getting them at, how much. So we'll talk about that again later on in the future. Because again, you guys will be able to be prescribing opioids now. Okay, the right route. So again, this is you have to make sure you're giving the drug via the right route, whether it be oral, whether it be rectal, IV, whatever it happens to be. You need to make sure it's correct. A really good example of this is a chemotherapy drug called vincristine. This drug, if you give it intrathecally, and oftentimes we are giving intrathecal drugs, again, that's in the spinal column, we're giving those drugs at the same time as we're giving other intrathecal drugs for their chemo regimen. They'll also be getting vincristine IV. If you were to give vincristine intrathecally, they're dead, right? That will kill the patient pretty quickly. And so because of that, there's been medication errors that have occurred there. We have certain practices we use now to make sure that does not happen. But again, the right route needs to be maintained there. Sometimes you can give medications via kind of non-traditional route. So a good example of this would be like a laxative, which normally laxative does what? Cause you to defecate, right? So you can actually put some laxatives in the ear. There's one called Docusate or Colase. You actually put that into the ear, the liquid formulation. It can help to loosen up earwax, right? So if you had someone who came in with this impacted cerumen, you can actually help to break that up, and then now they can hear again, right? So that could be one thing you could do there. Some cases we actually will give oral products intravenously. So there's one called N-acetylcysteine or Mucomyst. We'd use that for Tylenol overdoses, so you may see that occasionally. So again, if you see something odd, there could be a reason for it, or it could be an error that's going on. You can run into some issues if you give meds via the wrong route. You can cause like tissue necrosis and damage. For instance, if I give an anti-epileptic called phenytoin intramuscularly, that can cause some pretty significant tissue damage and necrosis to occur. Vitamin K, or another name for that is phytonadione. If you give that intramuscularly, that can also cause a hematoma. So again, the right route needs to be maintained there and giving things via the correct route that you intend. Right time. So again, timing of medications can be really critical here as well. So for instance, if I give acetaminophen too frequently, the liver can take a big hit there. So you can see hepatotoxicity. If I were to give pain medications too frequently, you can see increased sedation, respiratory depression potentially. Some cases, imagine emergency contraception. Anyone know an example of an emergency contraceptive? Yeah, Plan B, right? So again, you don't have to go to Plan C. You want Plan B to work, right? Well, there's a time frame with that. They need to use Plan B within 72 hours of the postcoital, the coital event, I guess. But they need it within 72 hours, and if they don't, there's an increased chance for failure, and you don't want that drug to fail, right? So timing is really important for that. If I give antibiotics too infrequently, that can lead to the infection either becoming more resistant or not clearing in the first place. So again, you want to give antibiotics like they should be given. If it's every 6 hours, then you need to take it every 6 hours. All right, so that's kind of the main things there. There's lots more that goes into medication safety, but those are the big things to kind of key in on and be aware of whenever you're prescribing a drug. Because again, there's multiple steps in the process, and you don't want to be, that first piece of Swiss cheese that's starting to line up all the holes there, right? You want to get it right the first time. Okay. And also, you don't want annoying pharmacists having to call you up to correct your orders all the time. So the fewer times we get to call you, which is my main goal in teaching you guys, so we don't have pharmacists calling and bothering you all the time. It's the main goal there. Anyway, just kidding. So going back to some definitions real quick before we wrap up. So again, we mentioned bioavailability. What is bioavailability? How much drug is getting into the system, right? So again, bioavailability, again, usually expressed as a percentage. IV bioavailability is 100%, right? Oral, though, can be what? Anything. Could be 0, could be 100, could be anywhere, right? So again, bioavailability is the amount of drug that actually reaches the site of action, regardless of the route of administration, okay? Now, bioequivalence is going to be when we're comparing two drug products together that have the same active ingredients, the same actual drug product, but we want to make sure they're identical in strength, concentration, the dosage form, all of that. The main thing where this comes up is going to be when we're talking about generic medications versus brand names, right? We mentioned during that drug development talk that when you get a new patent for a drug, you only have 20 years before it will go generic, essentially, right? You lose that patent. So once drugs come off of patent, that's when all these other manufacturers can come in with generics to show that, and what they have to show is bioequivalence. They have to make sure that they are getting the same concentrations, they're getting the same efficacy out of these drugs as the brand name, so that way they can market them, right? Because again, when you go into, and typically generics are cheaper or more expensive than the brands. Typically cheaper, right? So again, and as a pharmacist, our responsibility when we're dealing with like patients is to give them the cheapest medication possible. If we can show that they're identical to the brand names, then we can give them the generic and save them some money, right? That's one of our responsibilities. And so you'll have some people say, well, only the brand name works for me. The brand name just works better. Not usually the case, right? And in some cases, you may find there's some rare instances where that's true. But again, one of the most important effects you can find from medications is what? The placebo effect, right? So again, if patients think it works better, maybe it does work better for them in their own mind, right? So placebo effect is a huge factor here. But for the most part, generic drugs, they have to show that they're going to work just as well as the brand name. Otherwise, they can't come out in the market in the first place, right? So again, this is through the FDA. They have to prove this. So again, this can alter, or bioavailability can be altered by several different things here. You know, the route of administration, we talked about that already. The acid-base environment of the drug, or the environment is going to be solubilized in, whether it's protein-bound or unbound. All these things can affect bioavailability pretty significantly, as we'll see. And again, just looking back at this chart, you see kind of the comparison here between the different routes. IV should always be 100%. Everything else can be variable, though, right? Remember, bioavailability is also pretty much affected by the liver, because the liver does what? That first pass, we always want to keep that first pass effect in mind. That's primarily going to be affecting oral administration. Most other routes are going to be able to bypass that. Okay. So do you guys have any questions? I think I'm just going to go ahead and cut it here. Anything at all? Any lingering physio questions? Again, I will try to answer questions if you email me throughout the night, but again, I'll probably be in bed 11-ish, let's say that. So if it's after that, I probably will not be answering. All right, I'll see you guys next time.